Welcome back. As I said a moment ago, let's now continue with another big problem, the things that you and I do wrong: physician noncompliance, inadequate patient education, inappropriate drug dosing, inappropriate use or omission of diuretics. So here's a patient that you see that's taking a diuretic and a sympathetic inhibitor drug like a beta blocker, Pressor, clonidine, alpha-methyl dopa for those of you that still use it, and labetalol, or a vasodilator, the direct-acting arteriolar vasodilators such as minoxidil and hydralazine. And I've lumped calcium channel blockers and angiotensin receptor blockers under the vasodilator category, because if I put them out as separate drug classes, the slide would be expanded too wide and it might not fit on the screen or might not be large enough for you to see. And in fact, they do cause vasodilatation. They're just not thought of in pharmacology as direct arteriolar vasodilators such as hydralazine or minoxidil. So this is a rational triple drug regimen. On your left, let's call it column A, a diuretic; in the middle, a sympathetic inhibitor drug; and on your right, a vasodilator of the five types that we've talked about. And of course, this is a rational triple drug regimen. But as we're going to emphasize, we need to be sure that some patient is on something from column A, column B, and column C. So if a patient comes in, I see this all the time. A patient comes in on a good dose of an ACE inhibitor and an angiotensin receptor blocker and a beta blocker. Those are three drugs, even in full doses. But as I said a moment ago, those are three drugs that are attacking the renin-angiotensin system, and there's no reason to think that in these patients who are preordained for whatever reason to have difficult or stubborn hypertension to be controlled. So these are a couple of examples here of patients taking two different regimens. They're both perfectly rational, just like on the previous slide. So here you have a patient that's on hydrochlorothiazide, a beta blocker, and hydralazine. But what's the matter here? The dosages are not high enough. So hydrochlorothiazide, 12.5 milligrams once a day, is not an adequate dose of hydrochlorothiazide in patients who have difficult hypertension. Toprol XL, 25 milligrams once a day, that's nothing. As you know, the cardiologists always use Toprol 50 to 100 a day. Hydralazine, 25 milligrams twice a day. Cardiologists use hydralazine all the time in dosages up to 400 milligrams a day. We often see patients on hydralazine once a day. Hydralazine is at least a BID or TID regimen. In fact, it's better if it's given QID, but we try to avoid QID regimens today. So three good drugs on minuscule dosages, not resistant hypertension. Let's take the next one, Vasotec or enalapril, 5 milligrams a day. I could have made that 10 milligrams a day. Once a day enalapril is not quite as good as twice a day enalapril. Furthermore, 5 milligrams or 10 milligrams a day, that's child's play, that's nothing. That's almost a homeopathic dose. Now let's come to Lasix, 40 milligrams a day. Once a day Lasix, as my good friend Norman Kaplan likes to say, is the work of the devil, okay? Once a day Lasix just does nothing to control hypertension. Lasix lasts for 6, okay? You give the dose of Lasix, the patient pees like a bandit right after they take the dose, and then they're a little bit volume depleted, and for the rest of the day they have secondary renal salt and water retention. So at the end of 24 hours, they're right back to where they were when they started. This is the most common error that outside physicians make. It's the most common reason in my practice for physician noncompliance in evaluating resistant hypertension. And all I do is I take the Lasix, the 40 milligram pill, and I tell them to break it in half and take that pill twice a day. Or maybe if I think they need a little extra medication, I tell them to take that half of a 40 milligram pill and take it 3 times a day. Then all of a sudden the blood pressure comes right under control just from taking the Lasix the right way. And if you wanted to switch to a longer acting diuretic like indapamide or Zeroxylin or chlorthalidone, we'll come back to that, that would probably be even better. But in patients with renal insufficiency, and we see so many of them today in the aging population, Lasix is very commonly used. And so if you're going to use it to control blood pressure, you must use it in multiple doses. Let's look at nifedipine or Procardia XL, 30 milligrams. That's nothing. 30 milligrams is almost a homeopathic dose. If you're going to use Procardia XL or nifedipine, use 60 or 90 milligrams a day in the patient that is resistant. So the point of this slide is that we're looking at two good regimens, but the dosages are very minimal, and a patient on either of these two regimens whose blood pressure is not controlled does not have resistant hypertension. Well, let's now talk about a variety of regimens that a patient ought to be on in terms of dosage, and then fail. And then if the patient fails, you could call it resistant hypertension. So this regimen, which I've labeled Regimen 1, consists of a diuretic, a sympathetic depressant agent, and a vasodilator, such as hydralazine or minoxidil. So if you look at these dosages here, these aren't the kind of dosages that we're talking about for mild or essential hypertension, where maybe you're just starting a patient out. As I said at the very beginning, these are patients with extremely difficult hypertension, resistant hypertension. They're tough patients. You have to work harder to get them controlled. So get the dose of chlorothiazide up there. Or if you're using hydrochlorothiazide, get up maybe to 50 milligrams total daily dose, 25 BID. Or up to 10 milligrams of metolazone, or 25 milligrams of chlorthalidone, or 5 milligrams of indapamide that I mentioned a moment ago. If you're using the beta blocker, get the dose up there. If you're using atenolol, get the dose up there to at least 100 milligrams a day. And by the way, with regards to atenolol, that drug needs to be given on a BID regimen. 50 milligrams or 25 milligrams of atenolol is not very good in controlling the blood pressure. All the data suggests that. For those of you that still like to use atenolol, it seems to be falling out of favor. It's probably just fine if you use it in a dosage of 50 milligrams BID, but 50 milligrams once a day does not work. Clonidine, 0.8 milligrams total daily dose, and I would use it 0.2 milligrams TID. Remember, clonidine is the one drug that acts immediately. It has its peak effect in 1 hour, and then after the next 4 or 5 hours, the dose of clonidine dissipates. With regards to clonidine, I would avoid dosages of more than 1.2 total daily dose, because if you have a patient on clonidine and the drug suddenly gets stopped, the so-called clonidine withdrawal reaction that I know you're all familiar with doesn't occur unless you have a patient on more than 1.2 to 1.4 milligrams of clonidine total daily dose. So I never use more than 1.2 milligrams of clonidine for that reason, and I usually don't use more than 0.8. So that if you have a small patient, I don't have to worry, a tiny patient in terms of body weight, I don't have to worry about the clonidine withdrawal reaction. The other thing you might remember about the clonidine withdrawal reaction is that it may occur at a lower dose if a patient is beta blocked at the same time. So if you have a patient on a beta blocker and you want them on clonidine for whatever reason, because it is a very good drug in refractory hypertension, I never use more than 0.6 or 0.8 milligrams of clonidine total daily dose in a patient that's on a beta blocker at the same time. Prazosin or doxazosin, get the dose of those drugs up there. Labetalol, get the dose up to 600 milligrams total daily dose. Now what if you're using hydralazine? Some areas of the country use a lot of minoxidil. Get the dose up there, 200 milligrams of hydralazine or minoxidil, 10 to 20 milligrams a day. And remember that when a patient has seriously impaired renal function, when the creatinine clearance or the estimated GFR is less than 20 to 30 milliliters per minute, now you get estimated GFR in all your lab reports, the thiazide diuretics and chlorthalidone don't work very well when the GFR is severely impaired. That's when you have to switch the patient over to furosemide or torsemide, one of the loop diuretics. And if you're going to use furosemide, you must get the dose up to 120 to 160 milligrams a day, again in divided dosage when severe renal failure is present. With regards to the oral diuretics, I should tell you for completeness that chlorthalidone is making a tremendous comeback. Now, I've been doing this for a long time, and when I first came to the Cleveland Clinic, everybody used chlorthalidone. I grew up on chlorthalidone. As a matter of fact, the initial randomized controlled trials from the VA and the earlier ones showing the benefits of controlling blood pressure on cardiovascular morbidity and mortality were all chlorthalidone based. There's only one, maybe there's two, prospective controlled trials showing cardiovascular benefit that are thiazide based. Secondly, chlorthalidone is long acting. Third, in the comparative studies that are now just recently being done and have been appreciated from the past, is once a day chlorthalidone results in about a 6 to 8 millimeter further reduction in the systolic blood pressure versus the same total dosage of hydrochlorothiazide. So recommendations are increasingly being made to use chlorthalidone. And for the old timers that are listening to this webcast, I'm sure many of you have used chlorthalidone. Now, there is a problem with chlorthalidone. It's a practical one. It's only manufactured in a 25 milligram pill. And 6.25 milligrams or 12.5 milligrams is very effective. So you can get the 25 milligram pill scored, break it in half, and have them start on 12.5 milligrams a day. There's a 15 milligram pill, which is non-generic, called Thalatone, which comes in a 15 milligram pill, and you might prescribe Thalatone if it's not too expensive on the patient's health plan. So a bigger move back towards chlorthalidone over hydrochlorothiazide. Now, this is the second regimen. The comments about the diuretic and the sympathetic depressant are the same as I made before. With regards if you're using a calcium channel blocker as the third drug, the vasodilator category, again, get the dose up there of verapamil, diltiazem, Procardia XL, or amlodipine, which is now generic. Get the dose up there to 10 milligrams a day. Now, let's assume we're going to take a third regimen, the oral diuretic and the dosages that we just talked about. Sympathetic depressant agent was on the previous slide, but you want to use an ACE inhibitor or an angiotensin receptor blocker. Don't settle for Ramipril, 2.5 milligrams a day, or as I mentioned earlier, Vasotec or enalapril, 5 to 10 milligrams a day. Get the dose up there. If you're going to use losartan, 100 milligrams a day. If you're going to use irbesartan, 300 milligrams a day. Candesartan, 32 milligrams a day. Valsartan, 320 milligrams a day. These are people with difficult hypertension, so they have to have adequate dosing. Now, you see these patients that have refractory hypertension, always in the back of your mind is volume overload. Too much extracellular fluid volume on board as a big culprit in refractory hypertension. And the causes of volume overload are inadequate diuretic therapy, not a big enough dose or the wrong diuretic, or once a day Lasix, as we've discussed. Eating too much salt, as we've discussed. If you really reduce the blood pressure in someone that started out with severe hypertension, sometimes there is secondary fluid reduction from lowering the blood pressure below a critical perfusion pressure. And of course, progressive renal damage. You have someone with diabetic nephropathy, which is a common cause of very difficult to control hypertension. They often, the progressive rise in serum creatinine over time results in volume overload as a feature of the pathophysiology of hypertension involved in people with chronic kidney disease. And these could be reasons for lack of responsiveness to therapy. So in these patients, you got to measure their 24-hour urine sodium for sure, get them on a low sodium diet, and get them adequate diuresis. So here we are with this patient with difficult hypertension, and on your left, under the drug, they're on a diuretic, sympathetic inhibitor, and vasodilator. These next two slides are two of my favorites. I learned this also from my mentors, Bob Tarazzi and the late Ray Gifford. So the diuretic initially is doing a good thing in the middle column. It's producing negative salt and water balance. The patient may lose some weight, but over the next 3 or 4 weeks, the plasma volume and the heart rate come right back up almost to normal. So we're not quite clear on how chronically the diuretics lower the blood pressure, but at least acutely they lower the blood pressure by producing negative salt and water balance. So that is the good news. But on your right, you have counteractions. That's the bad news. As you know, diuretics stimulate the renin-angiotensin-aldosterone system. So you might have really cranked up angiotensin II while you've reduced the plasma volume. Beta blockers, clonidine, the alpha blockers, they cause modest secondary fluid retention. Now what about a drug like minoxidil or hydralazine? The good news is because they're direct arteriolar vasodilators, they decrease total peripheral resistance, but we have three things that are working against you. Because when you put somebody on a direct acting arterial vasodilator and you lower the peripheral resistance, you get a reflex increase in cardiac output, secondary fluid retention, which particularly in minoxidil can be very severe, and secondary stimulation of the renin-angiotensin system. So you keep increasing the dose of hydralazine or minoxidil, and the blood pressure keeps getting worse and worse because of these three counteractive observations. So, how do we treat drug-induced secondary pressor mechanisms? If the secondary pressor mechanism is fluid retention, promoted by vasodilators and some sympathetic inhibitors, they need more salt restriction or increase the dose of the diuretic. If they have secondary cardiac stimulation from minoxidil or hydralazine, they have to be beta blocked. If they have secondary hyperenanemia and hyperangiotensin II-emia from diuretics and vasodilators, that secondary pressor mechanism has to be counteracted by having a sympathetic inhibitor, a beta blocker, an ACE inhibitor, or an ARB on board. And very early on with diuretics and beta blockers, you may see a reflex increase in total peripheral resistance, and of course that can be prevented by the use of sympathetic inhibitors. So this physiology helps explain why when you put a patient on minoxidil or hydralazine, they must always be beta blocked first. So you know you have a patient with difficult hypertension. You think, at the end of the day, I'm going to have to put this patient on minoxidil. You better be sure you put the patient, before you put the patient on minoxidil, that they're adequately beta blocked, and then you've got to have them on a diuretic as well to counteract the secondary salt and water retention. Other drug interactions and actions that we have to consider are some sympathomimetics, nasal decongestants, very little, appetite suppressants, only certain ones. Cocaine is the big one. Too much caffeine. Oral contraceptives today we don't see very much as a culprit in causing refractory hypertension because the dose of estrogen is so much lower in oral contraceptives today than it was 15, 20, 30 years ago when I started out in this field. But about a year ago I saw 3 patients in the same week, 3 young women that had very difficult bad hypertension from oral contraceptives, so it does exist. Licorice, as may be found in chewing tobacco. Big ones that you might see are cyclosporin and tacrolimus in the transplant patient when patients are on these drugs. These drugs cause serious elevation of the blood pressure. Erythropoietin that we're all using to treat the anemia of chronic kidney disease and the anemia of other hematologic conditions may cause hypertension from the EPO. And NSAIDs is the big culprit. All the nonsteroidals are very well known to cause serious hypertension in addition to renal failure, but very commonly that's the culprit. I would say every month I see 2 or 3 patients whose blood pressure is not controlled and I find out that they're taking a lot of Motrin and Advil or Aleve continuously, and those are the big culprits. So the ones that you want to know about here on this list are the NSAIDs, erythropoietin, cyclosporin, cocaine, once in a while oral contraceptives. I think those are the big ones. What about cocaine? Massive increase in sympathetic nerve activity. Acute effects are hypertension and tachycardia. Chronic hypertension only in the setting of CKD. The treatment would be sedatives, alpha blockers, verapamil. Avoid beta blockers because that creates unopposed alpha adrenergic stimulation. And as you all know, these patients may come into the emergency room with terrible hypertension and chest pain caused by associated coronary vasoconstriction. Well, let's now turn to what's been called pseudoresistance, of which there are 2 broad categories. so-called pseudohypertension, which is caused by a stiff brachial artery, and that can be detected by Osler's maneuver, or so-called office or white coat hypertension, wherein there's high blood pressures in the office, but they're normal at home, or by ambulatory blood pressure monitoring. And you should suspect pseudoresistance in patients with high cuff measurements, but little or no target organ damage. So you see the patient in the office, the blood pressure is always high, 180 over 100. You're following this patient, you just can't seem to get it under control, but they don't have microalbuminuria. Their serum creatinine is 0.7. They have no LVH. You look at the eye grounds are fine. Or the eye grounds improve or the microalbuminuria goes away. That's when you might suspect that the true blood pressure is not as high as you're measuring it in the office. I don't detect Osler's maneuver very often, but if I see a very elderly patient with terrible peripheral vascular disease with a very wide pulse pressure and a very high systolic pressure, as Franz Messerli has long emphasized, you might check to see if they have the Osler's sign, which we all learned as medical students, to see if they just have a stiff brachial artery, which is the reason for the elevated blood pressure. But let's talk more about the big culprit today, so-called office hypertension. Pressor response to office visits controlled at home, not due to an inappropriate cuff size, obviously may lead to over-treatment. You see the patient in the office, the pressure's up, you keep on increasing the dose, then next week you get a call that the patient's having drop attacks at home. The clues to office hypertension, where many of us, all of my patients are on home blood pressure cuffs, disparity between home and office readings, postural symptoms or drop attacks at home, no evidence of target organ damage, as I mentioned, or even regression of LVH, retinal abnormalities in the face of persistently elevated office readings. So you see these patients that have high blood pressures in the office, and you want to sort that out. If there's a discrepancy between the home readings, which are normal, and the office readings, you might want to get ambulatory blood pressure monitoring, which is now reimbursable by most health insurance carriers and by Medicare. And you see this disparity between office and home readings. And you then want to check an ambulatory blood pressure monitor either for 24 48 hours. We do it routinely in our department. You might want to use ambulatory blood pressure monitoring to assess borderline or lay bowel hypertension, to assess the efficacy of therapy, to evaluate episodic hypertension or orthostatic hypotension, or clinical pharmacology studies of new drugs. No new antihypertensive drug can be released by the FDA without 24-hour data. And you know, we often see these patients that plague us in the office that have severe hypertension. They take their patients at home, they're very nervous, excitable people. They take their pressures at home, it's 200 over 120. They're always in and out of the emergency room with alleged hypertensive urgencies, and they come to you to help sort this out. And you take the blood pressure of the office, it's very high, and you hear this story, and then you put them on a 24-hour ambulatory monitor, and lo and behold, the blood pressures are all normal. They have a huge anxiety component to their hypertension. They're very difficult. We all see them, but they have normal creatinines, no microalbuminuria, no LVH. That's your clue that most of the time the blood pressure is normal, and you can sort that out with 24-hour monitoring. So now here's the real bugaboo in clinical medicine today all over the world. Now let's look carefully at this slide. It seems sort of boring. It's what we all learned as medical students. But if I go out and give this lecture at a medical grand rounds and there's 300 people in the audience, and I say, how many of you do this? There will be maybe 2 or 3 at the most that raise their hands. What we're supposed to do is have the patient come in and rest for 5 minutes with no conversation, seated comfortably, in a straight-backed chair, not on the examining table, where the blood pressure machine is against the wall, and the doctor has to hold up your arthritic arm with shoulder pain to measure your blood pressure. That's not the way to do it. That's not what the American Heart Association guidelines say. 2 seated readings should be obtained and averaged. 2 upright readings after 1 minute of quiet standing should be obtained and averaged. Over the bare arm, not over the shirt sleeve, not over the sweater, not over the leather jacket. Go to one of your local emergency rooms and watch what goes on in your emergency room. The patients rush in and the blood pressure is taken over the leather jacket, over the sweater. I have observed it time and time again in many emergency rooms, including our own. So this is the way it is supposed to be done. But in big office practices today, we're sort of under the gun to get the patients in and out, in and out, in and out. And in fact, this is virtually never done the right way. So in order to combat that, industry has figured out a way around this problem of the things that we do wrong in taking the blood pressure. And we have these automated blood pressure devices. This is what they look like. This one happens to be the BP True machine. There's one that looks just like it called the Omron machine. The cuff goes on the patient. The nurse takes the first reading, and then the nurse leaves the room. And anywhere from 3 to 6 readings are taken, a minute apart, 2 minutes apart, 5 minutes apart, however you set the machine. That takes the so-called white coat out of the equation. The patient's there by themselves, okay? And the machine then averages these readings. In our department, we use them routinely. Everybody in the Glickman Urologic and Kidney Institute, even the urology patients, get their patients taken care of by this BP True machine. The Cleveland Clinic has just purchased 500 of them. The Mayo Clinic uses them extensively in the so-called SPRINT trial, which is a multi-center trial. The Omron automated oscillometric device is being used, so there's several of them out there. And this just shows you what the reduction is of white coat effect. That's what WCE is, the white coat effect in clinical practice. And you can see blood pressure going from your left to your right by the family physician, the research physician, in the powder blue, the automated device, and then ambulatory blood pressure. And I call your attention to the bars to the farthest on the right. The automated device is reading the same as the ambulatory blood pressure. These automated devices are now being used worldwide, and I think they're going to change the whole landscape in terms of definitions of hypertension. So here's the ambulatory blood pressure, and this is what it looks like at the Cleveland Clinic in our department. So here up at the top, you see that blood pressure at the top left of 180/76. That's where the patient streaked in from the parking lot, late for the appointment, sorry that they're late, or something happened. They were aggravated from being out in the waiting room. We hope that doesn't happen too often, but you know that it happens in every doctor's office, so why not admit that it's true? The patient may be a little bit overweight at 200 pounds. But now look here what's going on. Now you see these readings every minute from 2:33 p.m. And these readings, here's the first one, this one is discarded. And then hooked up to our electronic medical record is this machine, and it automatically averages the reading. The 123/53, that's the average of 6 readings when the nurse is not in the room. That's the one that we use for decision-making and treatment of the blood pressure. And then if we could scroll down, you'd see the 2 standing readings that were normal, and they're averaged also. But here's the point. Look at these things in the green circle. The first reading, that's the white coat effect, which now disappears when the white coat is out of the room. Now, I don't mean to eliminate the possibility of an effect in elevating the blood pressure just from coming down to a big medical center and trying to find a place to park in a 12-story parking garage, but that for some reason, when the white coat is out of the room, it ameliorates a lot of the initial reading. And this even gives you this improvement in blood pressure when the American Heart Association guidelines are adhered to. Now you can imagine if you believed the patient had 180/76, you'd call it refractory hypertension. Patient's on a good drug regimen, 180/76, not a target, the differential diagnosis that I've just gone through. But that patient doesn't have refractory hypertension when you're getting around the white coat effect. It's a big problem in family practice and internal medicine, and all of our family health centers at the Cleveland Clinic are using these automated devices. Well, let's take a break there. We've covered patient resistance and physician resistance and white coat hypertension and drug interactions. this is a good time to take a break before we wrap up with a missed secondary cause of hypertension. Thank you.